Hello, my name is Dr. Kevin Helling, and I'm the Medical Director for Bariatric Surgery at the Wyoming Medical Center. I'm here to talk to you today about weight loss surgery and the various options that are available at the Wyoming Medical Center. We use a multidisciplinary approach to weight loss, and that includes behavioral therapies, pharmacologic therapies, as well as surgery to treat the problem of obesity. And we also treat patients with a diverse set of backgrounds and a diverse set of medical histories, including people with highly complex medical history. Again, we use a team approach that includes dietitians, mental health professionals. We have 2 nurse practitioners in our program, and we work closely with primary care providers both in Casper and in local communities. And then there's me, the surgeon. So what is obesity? And I asked this question. It sounds like a simple one, but it isn't always a simple one because it has a lot of social stigma attached to it. But obesity is a medical term, and it simply means excess body fat. Now we have a specific method of determining what is obesity, and we use the body mass index to do that. This is basically just a calculation based on your weight and your height, and it helps us to define obesity. And importantly, I want to emphasize the fact that obesity is a disease, and it's a disease with many symptoms and a disease with many causes, and I'm going to go into that in some detail here. So BMI, simply an estimation of your body fat. On the slide here I show the normal range, which is anything less than 25. Overweight is considered 25 to just under 30, and obesity is any body mass index over 30. So what is the significance of a BMI? The higher your BMI is, the higher the health risks associated with your weight. To give you an example, an adult woman with a body mass index of 35 has about a 50 times higher risk of developing type 2 diabetes over her lifetime. And we also know that as your BMI gets higher, your life expectancy actually goes down, such that by the time your BMI is 40, your life expectancy is 8 to 10 years shorter than it would be were you within the normal weight range. I've included a body mass index chart here for the presentation, but a simple way to find out what your body mass index is just to go to the internet and type into a search engine body mass index calculator, and you can find out what your personal body mass index is. Obesity is an epidemic. In the world, they estimate that about 1.8 billion people are overweight or obese. And that's an interesting time in human history now, because the number 1.8 billion actually matches the number of people who are starving in the world. So there are as many overweight and obese as there are starving people. Within the United States, approximately 72 million people are obese. And unfortunately, Wyoming is no exception to this trend. The Centers for Disease Control actually tracks this data fairly closely, and they published their most recent results in 2014 and showed that 28% of Wyoming adults are obese. Another 37% are overweight. So if you do the math, that leaves just about 1/3 of people, adults in Wyoming, who are at their normal healthy weight. So a true epidemic. And believe it or not, Wyoming is one of the healthier states in the nation, and I believe we rank number 9 for states in terms of obesity data. And beyond the significance of the health problems, it actually costs a lot more money, and the average obese patient spends about $1,400 more per year on healthcare costs, simply related to their obesity when you compare that to normal weight individuals. So many people have tried many things to lose weight, and it's not like anybody is trying to be obese. And so you can see on the slide here what I call the vicious cycle of weight loss. And it's very common, and I see people talking about it all the time in my clinic. First comes the decision to lose weight. People are initially very motivated, and they start a new diet plan, join a gym, they work very hard, and they initially see results. Most people will see some weight loss. They'll start to feel better. But with time and with continued busy life, people tend to slow down, and they find that it becomes more and more difficult to maintain that weight loss with the same efforts, and so they have to work harder. But eventually the motivation fails, and eventually they hit a wall, and eventually they fall off the wagon and regain their weight back. And this is a very common cycle. Many people even end up at a higher weight than what they started. And this is also very common when folks try Some of the latest trendy diets that limit your diet to only eating protein or completely eliminating one of the natural food groups, those diets tend to be less sustainable, and people tend to lose their motivation for those with time and tend to regain their weight. So obesity causes a wide variety of health problems, and most people know this intuitively. On the slide I've listed a number of the top health problems here, but there certainly are many more than this. Type 2 diabetes, high blood pressure, high cholesterol, sleep apnea, just to name a few, respiratory problems. Some types of cancer are more common among obese patients. Here's a picture demonstration of those health problems, and basically you can see there that just about every body system can be involved with obesity and have problems related to being obese. So what causes obesity? Many people believe that each person's body has an internal set point, or similar to a thermostat in the room that's keeping the room at a certain temperature, your body has a set point that's keeping you at a certain weight. And that patients who are obese have a set point that is set too high, like a thermostat set too high for a room. We know that the set point changes with time over the course of a lifetime. As a teenager, people tend to have a lower set point. Their energy level is higher, they eat less food, and they weigh less. But inevitably, as we grow older, through the course of our lifespan, our set point increases, and so does our weight. So what causes that? There are a variety of factors, and many of them are not completely understood. We do know that genetics plays a large role in obesity. There are over 80 genes that have been identified to date that are responsible for at least contributing to obesity. There hasn't been one single silver bullet gene that's been identified that could be a target of therapy, but we do know that genetics plays a significant role in obesity. There are environmental causes of obesity. Many people live a stressful, fast-paced lifestyle. That leads to skipped meals, that leads to rapid eating, quick meals. Some of the fastest, most delicious food to eat is the food that has the highest density of calories, is the least healthy. Also, there's this idea of portion distortion. For 50 cents more, you can get more French fries, more soda. Before you know it, you think you've been eating the same amount of food, but you've had an extra 400 or 500 calories in your meal. And then finally, a sedentary lifestyle is a major contributor to obesity. Medications can contribute to your weight gain, and this is another one of the vicious cycles of obesity. People who become more obese are more reliant on medications to treat their health problems. This includes medications for depression and mood disorders, diabetes, high blood pressure, etc. All of these medications can actually contribute to your weight gain, making it even more difficult to treat obesity. And then finally, we learn unhealthy eating behaviors. I don't know anyone who, as a child, didn't hear at some point, you need to clean your plate because there's starving children in some country. So it teaches a behavior to some people, even as a small child, to continue eating even past the point of feeling full. And then food is a very social thing, and we use food for a lot of reasons other than to sustain our nutrition. We use it to celebrate, it can be used as a reward or to show love. We use it for comfort and for socializing. So there are a lot of extra features of food and eating that play a role in developing obesity. So how do we treat obesity? One of the key points to understanding obesity treatment is that you know that it's a multidisciplinary approach and that no one method is going to treat obesity entirely, and that includes surgery. So we know very important, changing your diet. We need you to eat a healthy diet, a well-balanced diet. Exercise is also important. And then there is some role for medications for some people as well. And then finally surgery comes into play. But for any one of these to work, the others also have to be involved too. So even if you have surgery, you still are going to have to do diet and exercise to be truly successful. There are several celebrities who have had weight loss operations, and I've included their pictures here because I think some of their stories are very remarkable. The first one on the slide here is Rosie O'Donnell. She's been very vocal about her weight loss surgery. In fact, she had a heart attack and almost died, and that was a real eye-opening moment for her. And she's been very public about the fact that she had a sleeve gastrectomy and has lost a significant amount of weight. This actor was actually the person who portrayed Billy Bob on the movie Varsity Blues, and depicted an obese high school football player who was scrutinized for his weight. And he also has had weight loss surgery and looks great. Al Roker there as well. Randy Jackson from American Idol. And this person is actually less well known, but I added him because I think it's important to emphasize this type of person. This is Diego Maradona. He was a world famous top-ranked soccer player from Argentina. And he actually had weight loss surgery too about 8 years after he ended his soccer career. So even as a professional athlete who, was thin and extremely fit, once he changed his lifestyle and as he got older, he gained weight, and he benefited greatly from surgical weight loss. So who qualifies for weight loss surgery? We still use the same criteria that were put in place by the National Institutes of Health back in 1991. But to qualify for surgery, you need to have a body mass index of over 40, or you can have a body mass index between 35 and 40, but also suffer from a weight-related health problem. And then finally, you have to demonstrate an inability to achieve sustained healthy weight loss with previous weight loss efforts. So what happens when you decide you want to be evaluated for weight loss surgery? Again, we use a multidisciplinary approach, so you'll meet with a dietitian who's going to talk with you about healthy eating habits. You'll also meet with a mental health professional who, most insurance require this, but it's also important because not only do they screen for undiagnosed mental health issues, but they also help people to identify behavioral modification techniques that they can use to identify triggers for unhealthy eating and learn some coping skills that they can use to prevent those behaviors. We also work closely with the primary care providers, both locally in Casper and in the surrounding communities throughout the state. Sometimes you'll require a specialist evaluation. For example, patients with significant heart disease will often need to be evaluated by a cardiologist before they're cleared to undergo surgery. And then finally, there's the surgical evaluation with me. So who, finally, after all of this, is a good candidate for weight loss surgery? Number one, you have to meet the BMI criteria. Number two, in discussion between me and you, we have to decide if the benefits of surgery outweigh the risks of surgery. You have to present an acceptable anesthetic and operative risk. We also have to be sure that there are no untreated psychiatric disorders or ongoing substance abuse. And again, untreated. So psychiatric disorder in and of itself does not limit you from having surgery, but it has to be stable and well treated. Patients have to quit smoking before they have surgery. And that's not just to emphasize healthy lifestyle changes, but it's very important in the post-operative period to minimize your risk for complications. You have to be dedicated to a lifestyle change and lifelong follow-up with me. Once you're a patient in our clinic, you're always a patient. We'll end up following up with you at least once a year, more frequently than that in the time period immediately after surgery, but we'll always be following along with you in your weight loss journey. And you have to show commitment to the program, showing up for your appointments, that sort of thing. So what might cause your surgery to be delayed? Surgery could be delayed if further medical tests are required, if you need to meet with your cardiologist, if you require further psychological treatment, or if in meeting with the nutrition specialist they feel that you require more education to make sure that you really understand the post-operative diet. And then if your insurance requires a preoperative program, that can delay surgery. So what types of weight loss surgery are offered at Wyoming Medical Center? We offer 3 different types. First is the laparoscopic gastric bypass. It's been around the longest. Next is the laparoscopic adjustable gastric band, which has actually been done at the Wyoming Medical Center for several years. And then finally, and most popular, is the laparoscopic sleeve gastrectomy. There are other weight loss operations that we do on rare occasions. I won't discuss those here because those would come up on a very individual basis, and we could discuss those in the clinic. So the first operation I'd like to discuss is the laparoscopic gastric bypass. This is the oldest bariatric operation. The first one was done in the late 1960s. And while we've refined the technique quite a bit since then, the general principle is the same. It involves creation of a small pouch of stomach, which is connected to a loop of small intestine as shown in this picture here. This effectively bypasses the first part of the gastrointestinal tract. It also limits the amount of food that you can eat. And then additionally, it alters the body's hormonal signals for hunger. The advantage of the gastric bypass is that it offers the best weight loss. With this operation, we expect to see anywhere from 70 to 80% of the excess weight lost. What that means, for example, if you're 100 pounds overweight, we expect that you would lose 70 to 80 pounds with this operation. Many people lose even more than that. Another advantage is that the comorbidities, those health problems related to obesity, tend to go away very quickly after gastric bypass. The classic example of this is type 2 diabetes, where it's very common for us to have patients coming in on the day of surgery requiring oral medications, requiring insulin, having the operation, and then going home from the hospital off of all of their diabetic medications, even before they've lost any weight. And this is related to complex hormonal mechanisms in the body that are altered after the gastric bypass. Again, it's the oldest procedure. We have the most extensive long-term outcome data. So what are the disadvantages? Well, it's the most complex and it's the longest operation. It involves rerouting of the bowel. We create the small stomach pouch and attach the intestine to it. Anytime you make a new attachment in the GI tract, there are risks for complications from that. Bowel obstructions. The risk for ulcer is actually so high that once you've had a gastric bypass, you can't take pain medication of the NSAID class for the rest of your life. So that includes ibuprofen, aspirin, those type of things, because they tend to cause ulcers. And the one exception to that would be if a patient is on aspirin for a cardiac reason or for a medically important reason, they would continue that medication. I've included under the risk of complications tab something called the dumping syndrome, but some people would argue with me that that's not actually a complication. But dumping syndrome is a phenomenon when, if after a gastric bypass you eat a meal with a heavy sugar load, like a bowl of ice cream for example, the body senses suddenly that all that sugar is in the intestine and it gets confused. In order to dilute that sugar, it redistributes water into the bowel. And what that causes for you symptomatically is sudden and profuse diarrhea, which is miserable. And then about 20 or 30 minutes later, again in response to that high glucose load, the body overproduces insulin. So patients actually end up with a low blood sugar or hypoglycemia, which when symptomatic is a very miserable feeling, profuse sweating, anxiety, abdominal pain, nausea, vomiting, a very miserable situation. The reason why some people say that's not a complication is because it helps some patients to regulate what they eat, and it's a very powerful feedback mechanism for reminding patients not to eat those high glucose, high energy dense foods. The next operation that we offer is the laparoscopic adjustable gastric band. This operation is not new to the Wyoming Medical Center. They've been doing them since about 2008. This operation involves placement of a silicone band around the top of the stomach that's shown there in the picture. This creates a small pouch of stomach above the band. So when you eat food, that small pouch fills up quickly, you experience a sensation of fullness, and you eat less food. Gradually the food passes through the band into the stomach and is digested normally. The silicone band is connected to a piece of plastic tubing that's attached to a metal port that sits underneath your skin. And the amount through that port under the skin, saline can be injected to either increase or decrease the tightness of the band to affect more significant weight loss. Unfortunately, over the years this has become a much less popular option. Some patients are still very interested in the laparoscopic band, but we found over the years that it's less effective than we had hoped it would be. Also, many patients end up with long-term complications or require operative interventions for problems associated with the band. So, becoming less popular of an option as time goes on. Advantages of the lap band. The operation is shorter. It takes about 45 minutes to place an adjustable gastric band. It's also removable. I've been careful to use the word removable on this slide and not reversible, because once the band is in place, scar tissue will form around the band, and the tissue will never be the same as it was in its native unoperated on condition. We expect about a 40 to 50% excess weight loss over 2 to 3 years, so significantly less than the gastric bypass. And then the disadvantage, obviously the weight loss is less significant. The comorbidities don't resolve as quickly and are more reliant on actually losing the weight. So yes, the diabetes will go away, the hypertension will go away, but more as a function of losing weight over time. The other significant thing is that there's a 50% chance of reoperation with the lap band, and that could be for anything from the port being in the wrong position. Sometimes the plastic tubing can crack, but more significant complications can actually happen to where the band slips, causing an obstruction of your stomach, or the band can actually erode into the wall of the stomach, both of which can end up being a surgical emergency. And then finally, it's easy to develop adaptive eating behaviors to overcome the band. And many patients who've had the band will be able to describe the fact that if you eat soft foods, you tend to be able to eat more of them because they slip through the band more quickly. So here's a slide with those complications. As I mentioned, band slip, band erosion. Some patients have severe heartburn with the band. Sometimes food can get stuck and even require surgical or endoscopic removal. 1 out of 5 patients doesn't lose any weight with the band. That said, some people are very successful with the lap band. Those that are tend to get early and aggressive band fills. They're very disciplined about limiting their food intake of high density sodas and milkshakes and the soft, high calorie dense foods. Frequent upper GI x-rays are required to make sure that the band is in the appropriate place. And patients who are successful with the lap band have very faithful follow-up with both their primary care providers and with me, the surgeon. Finally, and the newest operation, is the laparoscopic sleeve gastrectomy. This involves removal of approximately 80% of the stomach. We create a sleeve of stomach which resembles a banana. Prior to surgery, a stomach can hold approximately 1 to 1.5 liters. After the sleeve gastrectomy, the stomach holds approximately 150 milliliters, so 10 to 15% the capacity. So this is very effective because it restricts the amount of food that patients can eat. But more interestingly, actually the part of the stomach that we remove contains the highest density of the hunger-stimulating hormones that are produced in your GI tract. So by removing this portion of the stomach, it actually removes the stimulus for hunger. Many patients after a sleeve gastrectomy will describe a change in how they feel about food. Their interest level is simply down. And a classic example of this, and I've heard this one more than once, are patients who go to the movie theater and they walk past the popcorn. And even though they just had a meal, smelling the popcorn, they feel hungry for it and they buy a big jug. Patients after the sleeve gastrectomy will describe walking by it and not even noticing necessarily that the popcorn machine is there. So effective at reducing the stimulus for appetite in addition to restricting the amount of food that a person can eat. So the advantage is it's highly effective. We see about a 60 to 70% loss of that excess weight, so somewhere in between the band and the gastric bypass, but more similar to the bypass. We see a similar fast comorbidity resolution with the sleeve, similar results with diabetes and high blood pressure. The other advantages, there are no new connections between the bowel and the stomach, reducing the risk of complications. There are no foreign objects that are implanted into the body, and there are no adjustments required over the long term. Disadvantages, it's slightly less effective than the gastric bypass. It's not reversible. Once that stomach is out, there's no way to put it back in. For some rare patients, it can be converted to one of the other weight loss operations, either a band or a bypass. But for the most part, patients do very well with the sleeve. Complications specific to the sleeve, because there's a surgical staple line, there's always a low risk of leakage along the staple line. That's about less than 1% risk of that. And then there's the risk of developing a stricture or narrowing at the opening of the sleeve. And this happens when scar tissue forms at the end of the newly created sleeve. It tends to happen over the course of several weeks, but the end result is that food is not able to easily pass through the stomach. This often requires another intervention. Most of the time we're able to treat it with an endoscopic dilation with a balloon, but sometimes it does require additional operation. So what is the safety of the surgery? First of all, every operation has risk. Bariatric surgery has become increasingly safe over the last several years, to the point where now the mortality is less than 1 in 1,000, which is similar to a laparoscopic gallbladder removal and is actually lower than the mortality associated with getting a hip replacement. Ways that we have improved the mortality over the years have been related to our perioperative care, our preoperative screening, the use of the multidisciplinary approach are all known to be effective interventions that have reduced the danger of the surgery. And then post-operative compliance with patient compliance with their visits to us has also been shown to improve the safety of the surgery. So medical problems that resolve after bariatric surgery are many, and this slide here is very similar to the slide depicting the health problems associated with obesity, but this one shows the health problems that get better after surgery. So what can you expect after your operation? Most patients will spend 1 to 2 days in the hospital. We get you up and walking around even the day of surgery. We find that it's very important. And again, one of those factors that's been shown to help with safety is to get out of bed on the day of surgery. So we're very strict about this one, and the nurses will help you to walk around even the night of your surgery. For those patients who are not able to walk around due to health limitations, we work with the physical therapist to find some way of getting you active immediately after surgery. You'll be on a liquid diet for 2 weeks following surgery, consisting mostly of protein shakes. And this allows time for the surgical sites inside your body to heal. And gradually after that 2-week point, you'll advance your diet, first starting with soft foods, but eventually back to a normal, well-balanced diet. Patients who have a bypass or a sleeve will be on multivitamins for the rest of their life. Again, by altering the GI tract anatomy, that limits your ability to absorb some vitamins, particularly with the gastric bypass. So lifelong replacement is required. For the sleeve, you're not able to take in as much food, and so that puts you at risk for developing vitamin deficiencies due to the fact that you just can't eat as much, and you don't get the full breadth of vitamins in your life. What to expect post-operatively? Again, once you've had surgery, you're a patient for the rest of your life, and even years after surgery, we'll be seeing you once a year to make sure that your vitamin levels are okay, to make sure that you're not putting on weight unexpectedly, to make sure that you're not developing any other problems. Immediately after surgery, you'll follow up with both me and the dietitian at about 2 weeks, again at about 6 weeks, and then 3 months. And then every 6 months, we'll check your lab work. We'll make sure your vitamin levels are where they're supposed to be. Much of this is able to be accomplished locally if you don't live in Casper and if driving here is a limitation for you. And then we're available any other time that you need us. If you're having a problem or there's something that you're concerned about, we're always available to either talk on the phone or see you in the clinic. But again, once you've had surgery, we will take care of you as long as you're around and we're around. So what steps do I take from here? You've already taken the first step, and that is that you're watching this video. Hopefully, after watching this, you recognize that obesity is a complex disease, that there are serious health consequences, and that we are here to help you. The next step in terms of beginning the process of qualifying for surgery, I need you to contact your insurance company and see if bariatric surgery is covered. If you get your insurance through your employer, you need to check with your human resources department to make sure that bariatric surgery is not on the exclusion list. Some employers exclude bariatric surgery from their coverage. And then also ask if the mental health evaluation is covered and if it's required. And once you've done that, then you've seen the seminar. We have you come in and see me in the clinic, and the phone number is listed on the slide there. Where to call to get your appointment to see me in the clinic. For those patients who don't have insurance or who are interested in cash pay options, that information is also available by calling us at the number listed there. We do everything we can to work with you, your insurance company, and your primary care provider to determine any preoperative requirements, any co-payments or down payments that will be required for the operation. We do participate with Medicare and Medicaid. A questionnaire has been included in your packet, which we ask that you have filled out before coming to see me in the clinic. And it's a very detailed questionnaire that may take a little while to fill out, but we really want to know all about you. We want to know your health history, your surgical history. We also want to know what you've tried in the past for weight loss, what's been effective for you and what hasn't worked so well. And all of that's on the questionnaire. And we ask that you have that filled out before you come, because when I'm meeting with you face to face, I'd like to spend that time answering questions and talking to you about surgical options and not spend that time filling out the paperwork. So we do ask that you have it filled out before you come. And then finally, I've included some useful websites on the slide here. One of my favorite is the asmbs.org. And this is a website put together by the organization that supervises all bariatric surgery programs. It's all very reliable and very up-to-date information. So I encourage patients to click on that website to gain any more information that they may be interested in.